The Senate Finance Committee is set to vote on its version of the health care bill today. You see there a live shot of that hearing. Joining us now is someone who has been very critical of Medicare as a government model for health care itself, former FDA Deputy Commissioner Scott Gottlieb. He's a resident fellow at the American Enterprise Institute, a partner at a healthcare investment firm, and perhaps most importantly, a practicing doctor. So you've got some perspective here from all angles. Sir, when you hear that this bill that is being heard right now on Capitol Hill is likely to pass, what worries you about it as it's scripted now?
Right. Well, it's likely to pass the Senate Finance Committee. It's going to move to the House floor, and that's going to be a whole different game. I think when you look at the bill, it's predicated on a premise that by expanding government control of health care, it'll give the government enough leverage to bring down the cost of health care. And it's going to do that by being coercive in terms of what physicians can do. So, for example, physicians are going to be capitated under this legislation. So the elements of managed care that people like the least, basically putting physicians on the financial hook for the tests and procedures they order, that's being incorporated into Medicare.
You're saying right now, the reason you're talking about Medicare is you don't think the government's an efficient market maker, essentially.
Well, the government's a bad purchaser of health care. That's the bottom line. And, you know, there's some laudable things in this legislation that tries to make the government a more intelligent purchaser of health care. But there's no history of Medicare being able to do that. And what they're really doing in this bill is trying to partner with physicians to get them to create financial incentives for doctors to become more efficient in what they do, to economize.
And what would make doctors become more efficient?
Well, one of the proposals in the bill is to actually revenue share with doctors. So if doctors can practice medicine in a way that's below cost, below an average cost of their peer physicians, they get to keep some of the leftover money. Now, that's been tried in the private sector, and it actually works, but people hated it because they felt that the doctors had a conflict of interest. They had an incentive not to prescribe certain treatments. That's what they're doing in Medicare now.
As you have people from the Cleveland Clinic and others that have been held up as models by the Obama administration saying the way to create more efficient care is, in one way, to create a salary for doctors rather than have it be pay for procedure.
Well, the bill certainly has incentives built in to try to drive consolidation of doctors into larger group practices. That permeates the entire legislation on the premise that when doctors practice in big groups, there's lower overhead costs, it's more efficient. It's interesting that whenever they talk about models of healthcare delivery, they point to private sector models like the Geisinger Clinic or the Cleveland Clinic. What those places do very well is they can track entire episodes of care. So rather than paying fee-for-service, they can pay for the treatment of a heart failure patient. Medicare can't track an entire episode of care. They've tried to do that. They haven't been able to.
Now, the public option, is there a way to make it efficient at all here, or you're saying just by definition of being government run, it won't work in your estimation?
Well, it's not a matter of efficiency. It's virtue of the fact that it's going to be anti-competitive. The government really can't compete in a private market in a free way. I think it's very unlikely you're going to see a public option to final legislation. It's politically just not viable.
Do you think that there should be more penalties for not buying insurance included in another bill?
Well, the private insurers certainly think so.
Right.
You saw
That's what they said yesterday.
Right, exactly. I mean, they're facing the worst of both possible worlds. They're going to be forced to insure everyone regardless of prior conditions, and they're not going to be able to make up what they lose on margin and higher volume. Basically, what's going to happen is you're going to see the Massachusetts model play out on a national scale where people will buy insurance just before they get sick.
But they won't have necessarily competitive choices out there, be able to, if there is a government option, and in reading this op-ed that you penned for the Wall Street Journal and the beginning of October, you were making the argument that lack of choice will make the healthcare providers not only less efficient, but less effective, I guess, here, because you won't have the option of walking out on your insurer if you don't like the treatment that they're providing.
Well, what you want is a marketplace where people can buy insurance that matches their particular needs and also what they're willing to spend on insurance. What they're doing in this legislation is creating federal regulation of insurance. So basically all plans are going to look the same. So if you want to go out and buy a catastrophic only plan, you're not going to be able to do that under this. You're going to have to buy a plan that's basically a cookie cutter plan. There'll be degrees of variation between plans. There'll be a platinum plan, a gold plan, and a bronze plan under this proposal, but it's not enough variation to really account for all the variation what people want.
So how do you make this process work better for the people itself? It sounds like there need to be more doctors or more healthcare officials involved in the penning of this. If you're saying there seems to be a lack of understanding of how the mechanics of actual care work?
Well, when things don't work, the default is to just apply more regulation to it. And Medicare's not an efficient regulator of healthcare. They have 20 physicians on their entire staff to insure 40 million Americans. If you compare that to private plans have literally hundreds, if not thousands, of physicians on staff administering health insurance. I think the way to really help consumers get access to care is to create a competitive market for people to go out and buy insurance on their own and buy the kind of insurance that they need to match their health needs. We don't have that in the United States right now.
And then we're going to need someone like you to explain all the fine print in that choice. That's the other difficulty. It's not an easy issue. It's one we're going to continue to watch and to follow. Thank you so much, Doctor, for joining us.